Hello, everyone. I'd like to welcome you to our presentation on the ACLP Diversity, Equity, and Inclusion Task Force, promoting critical change for our trainees, members, patients, and field. I'm Q Lee. I am the director of the Psychiatry Consultation Service at the San Francisco VA Healthcare System and the program director of the UCSF Consultation-Liaison Psychiatry Fellowship. I have no conflicts of interest to disclose. And these are the learning objectives that were listed in our abstract. I will be focusing on the second learning objective, which is understanding the process of how the ACLP task force developed its recommendations and report. So the process began in the spring and summer of 2020 when our board approved the formation of the DEI task force. Then incoming President Maria Tiamsin-Kassab asked me to chair the task force, which was a great honor. We then met with then President Michael Sharp and our Executive Director, James Rack, to discuss the task force's charge and membership. Ultimately, Michael Sharp came up with this charge, which was to identify areas of improvement and make recommendations to the board regarding DEI in membership and fellowship recruitment, committee and subcommittee appointments, board and executive committee appointments, the annual meeting, awards, and the ACLP journal. I want to give a big shout out to all the members of the task force who brought incredible wisdom, expertise, and thoughtfulness to the process of developing our report. Those members were Ken Ashley, Tina Bazai, Mark Bradley, Brian Bronson, Mary Jo Fitzgerald, Andrew Halls, Lena Mittal, Christina Montalvo, Sejal Shah, and Ray Young. And I learned so much, just a tremendous amount about DEI from all of the members. So I want to really thank each and every one of them. The task force had precepts which underscored the basis for our work, and these are listed in the report as follows. First, systemic bias and discrimination have demonstrably adverse health effects on our patients and reduce the professional and training opportunities available to our members. CL psychiatrists play a key role in translating our understanding of the psychological and structural harms of systemic bias into positive changes in medical practice, education, and systems of care. It is critical to ensure the sustainability of the implementation of the task force's recommendations across multiple dimensions of diversity, and we must acknowledge the intersectionality of these dimensions for CL psychiatrists, our trainees, and our patients. We must emphasize the importance of implementing our recommendations to create a culture that fosters a sense of belonging and inclusion, regardless of how members identify. And finally, DEI is relevant to multiple aspects of our field, including our work as educators recruiting trainees, as members of an organization seeking to recruit a more diverse membership, and as researchers and clinicians seeking to reduce healthcare disparities among our patients who come to us with diverse backgrounds and identities and varying degrees of disenfranchisement. So the task force met between September 2020 and January 2021. We met 4 times, and given the vast scope of DEI issues, we decided to create subgroups to develop proposals on how to enhance DEI in our membership, recruitment, leadership, and governance structure, including consideration of underrepresented medicine committees, subcommittees, and SIGs, how to institute pipeline and URM mentorship programs, how to incorporate DEI into webinars, curricula, and faculty development, and how to further develop CL Psychiatry's scientific contributions to research and other scholarship regarding the role of systemic bias in healthcare outcomes, including the creation and dissemination of a bibliography on relevant scholarly work. In addition, we created a subgroup to find out how other professionals' organizations were addressing DEI at the time. We also sought input from chairs and vice chairs of ACLP's committees, subcommittees, and SIGs. Among other groups, we received feedback from the Audit and Governance Committees, the Research and Evidence-Based Practice Committee and its subcommittees, the Residency Education Subcommittee, and what was then called the Women's Network. Given just how complex DI issues are, we did come up with some challenges that we needed to address. One challenge that we discussed at length was whether to recommend a standing DEI committee or a DEI subcommittee. I think we all very much want to recommend a standing committee, but the process for forming a new standing committee is fairly lengthy within ACLP. It usually starts with a proposal that is made to the governance committee. If the governance committee approves the proposal, then it moves forward to the board. The board then discusses the proposal, and there may be a back and forth between board and governance committee members. If the board approves the proposal, then the full ACLP membership votes on it. And if the membership approves, then there's a vote to change the bylaws at our annual meeting in November. Given the lengthy nature of this process, we would have had to start pursuing a DEI committee that was standing basically right after our report went to the board in February. And given the fact that we all felt a real sense of urgency to address DEI issues on a governance level, the board decided to initiate or form a DEI subcommittee, which they can do on their own under Lena Mittal. And that committee will do its DEI work until hopefully a standing DEI committee can be formed. Another discussion we had was whether to use the term cultural competency or structural competency on a report. Cultural competency is, of course, a term that has been used for decades now, but there have been recent concerns that the concept may lead to too narrow a perspective based on race, ethnicity, for example, when addressing mental health issues or think about mental health issues in a specific culture. So the task force chose to emphasize structural competency in the report, particularly in the area of education. And structural competency can be conceptualized as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or disease also represent the downstream implications of a number of upstream social determinants of health. This concept builds upon existing curricula on social determinants of health, cultural competency, and cultural humility. And I think this is really important to keep in mind that structural competency does not necessarily replace cultural competence, but really builds on that concept that has been developed over years. Structural competency also pays attention to forces that influence health outcomes at levels above individual interactions. Another challenge that we discussed was the scope of our report, particularly with respect to anti-racism. This was something that was getting a significant amount of attention over the course of our work in the aftermath of the police killings of Breonna Taylor, George Floyd, and others. We also discussed how much to address healthcare disparities. Ultimately, we decided not to make in-depth recommendations about these topics because they were not directly part of our charge, although we do reference them in our report. We made a number of recommendations regarding short and long-term action items. The immediate action items that we recommended were establishing a standing DEI committee, establishing a temporary DEI subcommittee, as I had mentioned before, that reports to this membership committee while pursuit of a standing DEI committee takes place, developing and implementing a survey and conducting focus groups on DEI with the assistance of a consulting, tasking all committees and subcommittees to develop a plan to focus on DEI issues relevant to their mission, establishing a DEI track at this year's annual meeting, and pursuing funding for URM pipeline program. The actions that have been taken to date include board approval for a consultant for a DEI survey, identification of workshops in our annual meeting as DEI relevant, so many thanks to Lisa Rosenthal for that. And we have formed the DEI subcommittee, as I've mentioned. We've met a couple of times, and we are in the process of discussing a choice of a consultant for the DEI survey. We're also planning for the coming year with a particular focus on education, the annual meeting, liaising with committees and subcommittees, and possible formation of URM caucuses. My colleagues will be discussing the recommendations that we made regarding governance, membership, pipeline, education, and scholarship. But Michael Sharp also asked us to make recommendations about other areas, which I wanted to address here. So with respect to the annual meeting, we recommended the establishment of DEI track, the establishment of an annual DEI plenary session, which could perhaps be funded by an ACLP award, more content on structural competency and healthcare disparities, such as systems issues as they relate to reproductive psychiatry, the inclusion of topics on DEI and healthcare disparities in pre-conference courses and sessions, implicit bias training, and networking opportunity for URM trainees and mentors. In terms of awards, we recommended, among other things, highlighting awards in DEI-related venues, identifying ways that our awards procedures may precipitate or perpetuate gaps with respect to DEI, as well as developing strategies for addressing these issues, and initiating awards for health equity and DEI work, perhaps similarly to the ACLP Foundation Research Professor and Early Career Research Mentee Awards. In other words, having an award for both a senior psychiatrist and a mentee. And for those of you who don't know, this graphic is of the NAACP Image Award. With respect to the Journal of the ACLP, the journal does have an online mission statement on the ACLP website that lists particular areas of interest. We recommended adding DEI, anti-racism, healthcare disparities, and cultural and structural competencies to that list. We also recommended devoting special issues to these areas, regularly reviewing articles for use of pronouns and non-stigmatizing, non-biased language, and assessing articles for the risk of bias and for generalizability to underserved communities. For those of you who are interested, our task force report is posted on the ACLP website, and this is to the link to that report. Here are my references. And with that, I'll say thank you and turn things over to Andrew Halls, who I'm very proud to say was my fellow last year, and he will be talking about DEI with respect to ACLP's membership and governance structure.
All right, well, great. Thank you, Q. I'm Andrew Halls. As Q mentioned, I was a fellow member of the task force during the process last year. Now I grew up and I'm an attending psychiatrist at the Zuckerberg San Francisco General Hospital, which is San Francisco's safety net hospital for the county. And I'm looking forward to talking to you all about how the task force came to its recommendations about membership, governance, and structures. So I have nothing to disclose. I'll just want to highlight the folks who were with me in the subgroup. So Lena and Ken contributed significantly to the things I'll talk about today. So our subgroup met with this task. We were asked, how can we enhance DEI in ACLP membership, recruitment, leadership, and governance structure? And then kind of to take that and guide it more specifically, or ask ourselves, what's the point of this whole thing? Really, the reason we're even pursuing this topic is to ask ourselves, is ACLP working as it should? And how would we know if it was working? So we came up with this working definition for what organizations are supposed to do and use that as we thought forward. Is the structure working? Who is the members? What's the governance like? So here's our definition. We thought that structures of organizations should, 1, serve the needs of its communities, and 2, reflect the priorities and values of its members. So I use the word structure, which you've heard already before. I'll just make a comment on that. Q mentioned it in his last talk a few minutes ago. He used the phrase structural competency. So when you hear structure, have those concepts in mind. I have his definition here on the slide for you to look at. You might have also heard structure in terms of this phrase, structural racism. You might hear related terms like institutional racism or systemic racism. And so I want this to come into your mind when you hear structure. Realize that structures or policies and practices may intentionally or unintentionally generate or perpetuate inequities. And thus we should take a look at our structures and make sure that this is not happening. And then practically speaking, what is a structure? Well, you can look at the way an organization is put together. Sometimes people make these things. You might have heard of an org chart, which is short for an organizational structure chart. So this is how it might practically look like in practice. So if we hop back to our guiding question and definition, we thought in our subgroup, we needed to figure out what exactly is the structure of our organization and who are the members, and is the organization working for its members? So what I'll do is walk you through really briefly what our structures are, and then go from there. So you may know that there are 8 standing committees. Here they're listed on the left: the annual meeting, audit, education, finance, governance, membership, nominating, research and evidence-based practice committees. Many of them have subcommittees. So you can see here on the right is a screenshot from the ACLP website. And you can see the annual meeting committee has several subcommittees that report to it. And these 8 standing committees report to our board of directors. So here is a screenshot of the website that shows the 2020 to 2021 board of directors. So these represent our leadership. And then another important structure we realized is that our special interest groups, or SIGs, form actually a really big part of the culture of ACLP. There are over 20 of them right now listed on the website. And I want to highlight a couple of them also as our talk revolves around DEI. I'm highlighting here a few SIGs that already have a focus in mentorship and networking for underrepresented and or historically disenfranchised members. So for example, early career psychiatrists, special interest group, focuses on psychiatrists who are new to the academy or new in practice and may historically feel like their values are not yet reflected in the entire academy, or the new recently formed Hispano-American CL Psychiatry SIG, which unites people who are outside of the United States, hoping to bring CL into their work. And then there are several SIGs that have a focus on advancing the care of underserved populations. Now, you might argue that many SIGs have this as a part of their focus, but I highlighted a couple that represent that really well. So the global and cultural SIGs, the HIV psychiatry SIGs, and the women's health SIG all have that as a core value of their groups, advancing the care of their particular populations. And then when you ask who's the community we serve, there's a few people who are obvious. The members of the academy are part of the community, but ACLP has a vision to reach outside of that. So I believe the academy tries to serve not only the members, but non-members who are CL psychiatrists or CL fellows too, or people who are thinking about fellowship, like psychiatry residents or medical students. And then many of us thought on the task force that really our academy also serves the greater community of patients also. And so thinking through the structure of our academy, we want to be sure that it served all these different stakeholders and members. So thinking about that, our group came together and identified some early gaps or deficiencies in how the structures were supporting our members. The first is we found, while there's a lot of information available on the website showing us how our structure is made, how our governance is determined, there wasn't demographic data of our membership readily available. And therefore, we found it hard to really say for sure how our members may or may not be represented by the leadership and the board of directors. We also noted that there was no existing ACLP committee or subcommittee at the time that had a focus on DEI. And while there are some SIGs that have this interest, there are a lack of SIGs focused on other vulnerable and underserved populations that there is no SIG for. There weren't SIGs supporting some specific underrepresented in medicine groups. And then there weren't SIGs that focused on other skills relevant to the service of underserved populations, particularly through the lens of structural anti-racism and cultural competency and humility. So we made some recommendations based on those early gaps. Q hinted at a few of them already. One was that we recommended forming a full standing DEI committee. One of those reasons is we thought it was important to have a standing committee to demonstrate its importance to our community as being a priority on par with the mandates of the other standing committees. So for example, while standing committees serve practical purposes, especially for example, the audit and finance committees, they also highlight what our key values are and strive to advance the mission of ACLP. For example, education and research committees have that as a core focus. Another way to look at it is, here is a little figure showing each of the existing standing committees. And DI work is kind of cross-cutting all of them. It felt to us that it was not only as important, but needed this kind of place where it could oversee or help guide the other committees without assuming it fit into any one box. So let me walk back and give you an example. At the annual meeting, there are many places where DEI should be considered, like are the speakers being chosen in an equitable fashion, or do people feel included? Is there easy access to attend the meeting? Is it fair? When it comes to education, are potential fellows being recruited in an equitable manner, and so on and so forth. Other recommendations we had were to not only create a committee, but ensure that it is funded with the necessary resources so that we could effectively generate, review, and analyze the data that we found was missing, including data on the differences or gaps between our leadership and membership, differences or differences or gaps between current members and non-members and people who are considering membership, data about factors that may persuade or dissuade membership, especially of those who might be underrepresented in medicine, including identifying any structural biases that might be built into our academy, data about strategies to narrow those existing and ongoing gaps, including increasing recruitment of underrepresented in medicine folks to attend our meetings, pursue fellowships, and join, and ways that our leadership search processes, our nomination procedures, our committee appointments, and our bylaws may be, whether intentionally or not, precipitate or perpetuate gaps with respect to DEI and strategies for addressing such. And ways that ACLP might engage in advocacy for patients who are impacted by healthcare disparities. I know I've said many recommendations. This is the last slide on this. We had other recommendations, including tasking all committees and subcommittees to engage in DEI work, collaborating with similar groups that already exist in sister organizations, like at the APA. And then we wanted to be clear that we want the Academy to openly welcome leaders from diverse backgrounds to form new special interest groups with a key focus in the following areas we thought needed extra attention: in the service of vulnerable and underserved populations, in psychiatrists who might be underrepresented in medicine, and in key conditions or factors affecting underserved populations. And then our subgroup just wanted to make a few other acknowledgements. First, SIGs have been core to the culture of ACLP, and you might see this right on our website. They have for many years provided vital networking, mentoring, and collaborative support to hundreds of members. And for that reason, we focus some of our recommendations on SIGs and how to help them be better. That we recognize that ongoing self-appraisal of organizations is essential in order to identify gaps and redundancies and to develop new processes where indicated. So this shouldn't be a one-time thing. This should be an ongoing process. And as our current structure is put together, committees and subcommittee members are currently selected by leadership. And so we felt strongly there should be efforts to increase the diversity of membership on all committees and subcommittees by recruiting and selecting diverse volunteers. All right, if you want to read some more, here are some references, including where you can find this information on the ACLP website yourself, and some great resources that the APA already has in this area. All right, and with that, I'd like to thank you all for your attention. I'm going to pass it along to Christina Montalva, who will talk to you all about our recommendations for a pipeline program.
Hi, everyone. I'm Christina Montalva. I'm the Chief of CL Psychiatry and Emergency Psychiatry here at Tufts Medical Center, and affiliated with Tufts University School of Medicine and BU School of Medicine. I'm here to talk to you a little bit today about the DEI Task Force and the proposed pipeline program. I have no financial disclosures. So some of the objectives that I'm going to speak about today are developing a greater understanding of the benefits of pipeline programs, how these programs support recruitment and retention within ACLP, and a quick review of literature and other programs that have established these models. So where do we begin? A lot of us think about being in high school, early undergraduate education, and wanting to follow the path of medicine. As you can see, not everyone follows that same path, and eventually there's some of us that get to medical school. We subsequently continue to filter people out and go on to residency, and if so determined, to go into a career of academic medicine. But how do we get here, and where are there opportunities to improve the pipeline so that we can continue to build ACLP into the wonderful and diverse specialty that we already are? Some of the goals around the DEI task force of creating a pipeline program was really to think about how do we expand and improve our opportunities for mentorship as each of these individuals, nationally, continue to try to explore what careers they'll go into and how they get exposure to CL psychiatry. Our goal was to identify trainees, and this extended to medical students as well as residents, knowing that very early on in their training, they will make decisions about what specialties they'll go into within psychiatry and even specialty fellowships as well. And the dimensions of diversity that we wanted to consider were not limited to race, ethnicity, sex, gender identity, sexual orientation, socioeconomic circumstances, nation of origin, geographic background, immigration status, and religious beliefs, because really looking at all of these factors will help us really make our specialty as robust as possible and provide a better care to the communities that we treat. Finally, we wanted to think about cultivating interest in serving underserved populations and recruitment into CL psychiatry, which, as we know, year after year, is a topic of interest. It's not new news that the distribution of medical residents by race and ethnicity does not reflect the communities that we serve. This is the report more recently from AAMC from 2019 and 2020. And we're not the first organization to consider what we need to do for a pipeline program. Here on the right is actually my home institution and my alumni, New Jersey Medical School, originally called UMD&J, now Rutgers, who has created a pipeline program starting as early as high school so that they can engage the community better and have a better understanding of how we can support them as physicians later on and build their careers into future doctors. Other programs extend into medical school, undergraduate, graduate school programs that look about how we start these programs and create a pipeline. So to provide the mentorship that we've discussed and also build their careers into future physicians who subsequently can give back to the communities and have a better understanding of what the communities, how to address their medical needs. The APA is currently offering various early pipeline programs, and this includes the Workforce Inclusion Pipeline Program, mentorship for Black men, Indigenous people, as well as Hispanic individuals, as a means of exposing undergraduates to the field of psychiatry. Through recruitment from undergraduate programs, they're trying to increase the number of underrepresented medical school applicants, primarily focused on the field of psychiatry. And their thought is that through an early pipeline program, we can start having better mentorship and career advancement for a more equitable workforce within psychiatry. The AMA continues to have physician diversity as a priority, with it being its major focus of its 2019 AMA annual meeting. And at that meeting, there was a large request and need, and the AMA House of Delegates really directed the AMA to support publication of healthcare career pipeline programs and pathway programs in the nation, with the goal of increasing the number of programs promoting leadership, development of underrepresented minority healthcare professionals in medicine and the biomedical sciences, with a focus on assisting these programs and identifying best practices. So we still have a way to go, but we have wonderful leaders who are looking at this in big organizations. And we know AMA is still working with stakeholders, and they're looking at allied health professional societies, establishing biomedical science pipelines, and we can be part of this to best support ACLP and the national, psychiatry and AMA organizations as well. It always comes down to money. And so oftentimes the idea is, where will the funding come from? APA externships and grants are supporting diversity, and they're supported by funds from multiple locations, including the Substance Abuse and Mental Health Service Administration, or SAMHSA, the Department of Health and Human Services, and this sponsors their Minority Fellowship Program, which I am very proud to say I was a product of, and something I found extremely valuable. AMA, Accelerating Change in Medical Education Innovation Grant Program, has awarded up to $1.5 million in grants since 2018. So really an untapped resource that our smaller organizations, specialty organizations such as ourselves can consider. And these grants are issued to undergraduate and graduate medical education faculty to provide financial support, not only to transform the education they're providing, but also to improve the healthcare systems, and grants to focus on diversity and inclusion, to provide more mentorship opportunities, to advance the careers of these individuals. Just to give you a sense of what a budget looks like, this is the budget for the APA Addiction Psychiatry Externship, which lasts 1 month within a facility with an addiction fellowship. And the award there is $2,000 for living expenses, $400 for travel expenses from to and from the mentoring site location if it's out of state, and $100 book allowance. Really not a big push for ACLP to kind of consider what we could do that's similar to this, knowing that other specialties within psychiatry are considering these opportunities. What are the benefits of this program? We would support visiting medical students and residents to spend a limited time at a designated site where they'll get a hands-on look at how psychiatrists treat patients with comorbid psychiatric and other medical illness within the specialty of CL psychiatry. It's an opportunity to network nationally with medical school and psych residency programs, so they can learn sooner about CL psychiatry and get real life exposure. So we can also show them the diversity of the patients we treat. It would identify a diverse range of ACLP members that would be willing to serve as mentors. So this would be a new opportunity for those who are interested in mentoring and providing oversight to medical students, teaching them, and that could be anything from research, education, administration, or career development. And you could consider fellows, early career, mid-career, or senior mentorship opportunities. Formal mentorship training would be provided to mentors who would be volunteering for this. And that would include implicit bias training, education on microaggressions, utilize mentorship training resources already adopted by the ACLP and that we've discussed a bit, and more discussion around formal education will be followed after this presentation, and other resources. Finally, this would be a network opportunity for other mentees. We as ACLP could consider, as was already discussed, DEI Mentee Awards to recognize these individuals, whether it's based on clinical valor, research opportunities, or just being a pioneer in education and training a diverse workforce. In regards to acknowledgement, I'd like to acknowledge my collaborator, Raymond Young, who worked on the pipeline program outline for the DEI task force, as well as the general ACLP DEI task force. And thank you very much. And now I'd like to introduce Tina Bezai, who will be speaking about education.
Good afternoon. My name is Tina Bezai, and I am the Program Director of the Consultation-Liaison Psychiatry Fellowship at UC San Diego, and also the Medical Director of Integrated Hospital-Based Programs at the VA San Diego Healthcare Center. And I'm going to present the proposal for how to incorporate diversity, equity, and inclusion into education across the ACLP. First of all, with respect to the following presentation, I have no conflicts of interest to report. Our charge was to develop a proposal on how to incorporate DEI into curriculum, webinars, member development resources, including those used by CL Fellowship program directors and faculty. Our review process was a literature review, input from ACLP committees and subcommittees, a review of the ACLP website, ADPERT, and AAMC materials. First of all, I'm going to speak about the framework transition from cultural competence to cultural humility. The cultural competence framework was developed in response to an Institute of Medicine report in 2002. which reported on the rapidly evolving demographic composition of the United States and the need to develop increased diversity in the healthcare workforce and skills to deliver the quality of care for diverse patient populations. It was defined as the acquisition of cultural knowledge about population subgroups, the adoption of culturally sensitive attitudes, and the acquisition of cross-cultural skills. This framework, at least parts of it, were housed within the ACGME competency domains. Model curricula were developed, and they approached competency across the training years with a developmental trajectory. The recommended comprehensive training extended to areas of diversity beyond race and ethnicity. As my colleagues have mentioned, there have been challenges and critiques of the cultural competence framework. One of the challenges was that it assumed that there was a quantifiable set of attitudes and communication skills. It utilized a categorical approach, ascribing values, beliefs, and behaviors to broad cultural groups that might lead to stereotyping. It implied a final and static goal of medical knowledge acquisition. It ignored power dynamics, and it ignored more nuanced perspectives, such as intersectionality, including individual, interpersonal, and societal influences. And so the cultural humility framework is now the recommended approach. Cultural humility is defined as the ability to maintain an interpersonal stance that is open in relation to aspects of cultural identity that are most important to the patient. This is viewed as a continual process, not static in time. It requires self-reflection, self-critique, active listening, relationship building. It's patient-centric. It emphasizes patient-focused interviewing and care. For example, how to understand how personal biases and stereotyping may affect treatment. Minimizes the power imbalance and acknowledges the dynamic and multidimensional nature of culture. There's no assumption of cultural competence. It normalizes the process of not knowing. And so a goal is to train clinicians and healthcare workers to be culturally humble with patient care and teamwork, which includes diverse members. So questions for our group included, are there current standards or expectations within CL psychiatry? What educational resources specific to CL psychiatry exist? Which, including workshops or trainings, should be revised, developed, or expanded? And who is our target population, our community? Members, trainees, program directors, and others. Many CL psychiatrists work as members of interdisciplinary and interprofessional teams that also will need education. I wanted to touch briefly on the ACGME requirements dated July 2020 that touch upon some of these issues. One of the general ones is, the general requirement is that programs must understand the social determinants of health of the populations they serve and incorporate them into the design and implementation of the curriculum with the goal of addressing these healthcare disparities. The domain of medical knowledge includes the requirement education about American culture and subcultures, including immigrant populations, particularly those found in the patient community associated with the educational program, with specific focus on the cultural elements of the relationship between the fellow and the patient, including the dynamics of differences in cultural identity, values and preferences, and power. The domain of systems-based practice includes fellows must demonstrate an awareness of and responsiveness to the larger context and system of healthcare, including the social determinants of health, as well as the ability to call effectively on other resources to provide optimal healthcare and quality improvement. Fellows must receive training in QI processes, including an understanding of healthcare disparities, and participate in interprofessional QI aimed at reducing healthcare disparities. How do these apply to our profession? We reviewed the ACLP website, educational resources. We have a very well-developed, I want to say, educational component to the website, and it includes monthly webinars, quarterly annotations on a variety of topics, bibliographies, including specialty bibliographies, a live learning center with a maintenance of certification program, clinical pearls, which include videos, clinical monographs, resident curriculum, which is a series of PowerPoints developed in 2014, resident CL how-to guides developed in 2020, and CL Fellowship Program Directors Clinical Vignettes for Fellow Evaluation developed in 2011. I'm sharing some screenshots of our ACLP website for those who are not as familiar or just want to review briefly together what we currently have. This is the ACLP monthly webinar page, and you can see different topics that were completed in 2019. This is the bibliography page, which includes ethics training, ethics bibliography, HIV/AIDS bibliography, psychological considerations bibliography, the addition of women's health. There are some broader topics below. Clinical monographs, which are our evidence-based knowledge summaries. We have a variety of different ones. I'm just sharing here: collaborative care, delirium, aggression and violence, catatonia. CL curriculum for psychiatry residents. These are a variety of PowerPoints with topics that span all the educational requirements. CL how-to guides are more detailed documents for trainees, which include treatment algorithms, management tips, developed in 2020, a variety of topics again. And finally, the clinical vignettes for fellow evaluations. These are case-based scenarios with subsequent discussion points, with areas that target ACGME competencies, covering these topics. So educational gaps, we noted, were gaps in integration across the materials of cultural humility, structural competency, and DEI factors. More specifically, individual, interpersonal, and structural barriers that may prevent culturally diverse populations from obtaining mental health services, implicit biases that may interfere with clinical judgment and working to address biases, the application of knowledge of cultural differences in the symptomatic presentation to the clinical formulation, evaluating and incorporating cultural strengths in treatment interventions, evidence-based psychological and pharmacologic interventions specific for diversity, and identifying ethnopharmacologic factors that may influence response. These are our recommendations: to develop expectations and standards of structural competency, cultural humility, culturally appropriate care, and DEI in CL psychiatry; to develop a section on the ACLP website with educational, curricular, and member faculty development resources devoted to DEI, racism, structural competency, cultural humility, culturally appropriate care, and healthcare disparities, including factors contributing to these disparities, such as language proficiency, health literacy, and other social determinants of health; to develop a bibliography of textbooks and articles relevant to structural competency, cultural humility, culturally appropriate care, DEI, and healthcare disparities in CL psychiatry; to review our posted residency CL curriculum in order to integrate DEI factors across; to review our fellowship vignettes to integrate DEI factors across; to develop a regularly scheduled webinar dedicated to teaching on racism, bias, and health disparities within CL psychiatry; to develop a webinar on critically evaluating the literature on cultural and DEI topics; sponsored training that addresses racism, discrimination, implicit bias, and microaggressions toward patients, trainees, other staff members, perhaps with input from training programs that are leaders in developing such curricula, and to create faculty development sessions related to diversity that could be used to help meet the ACGME's diversity requirements for residency and fellowship programs. I want to acknowledge Sejal Shah specifically. She was my co-education subgroup member, and the ACLP DEI task force, the ACLP residency education subcommittee and work group, the fellowship education subcommittee, and the member student education subcommittee. They shared thoughts, ideas, and ways to move forward with this important topic. These are the references, and thank you. I want to now introduce Mark Bradley, who's going to be speaking about DEI in scholarship and research.
Okay, I'm Mark Bradley. I'm very excited to be joining you today to talk about DEI in scholarship and research. I am clinical professor of psychiatry at NYU School of Medicine. I'm section chief for the VA New York Harbor, and I'm the chair for the ACLP Fellowship Education Subcommittee. And I don't have any financial disclosures to make. So by way of overview, I'm going to first review the rationale for diversity, equity, and inclusion in CL research. I'm going to discuss some of the barriers to and opportunities for DEI in research. And then I'm going to talk about how these were used to inform the DEI task force recommendations for scholarship and research for ACLP. So by way of background, when we talk about our recommendations and the development process for thinking about diversity, equity, and inclusion in research, we really have to think about two overlapping sets of events that occurred in 2020. And the first one of those was the murder of George Floyd and a number of other high-profile police killings of Black individuals that exposed in a very public way, not only a problem of policing against Black individuals, but a larger problem of how our identities of advantage and disadvantage differentially shape our experiences with everyday institutions that we encounter throughout the world and through society, and how these shape our health outcomes. And the second event, of course, was the COVID-19 pandemic, which exposed underlying fissures in terms of equity and justice in healthcare and showed stark disparities, particularly by race, in terms of exposure to COVID-19, social vulnerabilities to COVID-19, COVID-19 infection, death, access to vaccination. This is, of course, a series of disparities that continue to have ripple effects in our society. We saw a publication this week in Pediatrics showing that the burden of parental deaths is significantly differentially shouldered by young people who are Black and brown compared to white people. And so these are very significant disparities that shape the healthcare outcomes of many people of historical disadvantage. So these foregrounded the ways that racism and other social injustices are an ongoing public health crisis that require further critical inquiry and research in order to understand and intervene on. And as a result, a number of medical organizations, including our own, called for increased focus on racism and other social determinants in healthcare, and including in research. So at the same time that ACLP was scaling up to address diversity, equity, and inclusion throughout its organization, including in scholarship and research, a number of other large high-profile organizations were also considering ways to address disparities and DEI within their organization. These included the National Institutes of Health, which released the UNITE initiative. And the UNITE initiative pledged to fund new research on disparities and minority groups and to try and diversify research. It also committed to improving the NIH culture for equity and inclusion. At the same time, one of our premier research organizations in psychiatry and neurosciences, the American College of Neuropharmacology, published a statement on advancing equity, diversity, and inclusion. And this statement focused on organizational diversity, and in particular, taking steps to improve equitable access to membership and conference attendance. And it's worth noticing that although both of these initiatives were embraced as attempts to make step forwards in addressing issues around equity and diversity and inclusion, they were also criticized for failing to fully address the underlying needs. So for example, with the NIH, there was criticism that there was a failure to commit to ensuring that Black investigators were funded on par with white investigators, which continues to be a problem. And it was pointed out that in spite of the ACNP statement that still only about 1% of membership in ANCP is Black, and that these have failed to be remedied over the years. They were also caused by many medical, especially journalists and professional organizations, to incorporate social determinants into medical research. So why is it important for DEI to be addressed in research? Well, so the events of the recent years have illustrated this, but even before that, there has been an increasing accumulation of research showing that the health outcomes of disadvantaged communities are largely socially determined, and that further research into these social determinants remains underfunded. So our funding institutions tend to differentially fund research that is more narrowly focused on biomedical outcomes or biomedical mechanisms without fully engaging with the social contexts that actually drive health outcomes for most people of historical disadvantage and exclusion. In addition, the mechanisms of these health disparities need to be further understood in order to develop interventions to try and remedy them. And to date, biomedical research has failed to address these disparities. And so what we're seeing is that there are many interlocking institutions of disadvantage that affect the downstream effects of many communities. And we've seen this most particularly in the events of recent years around the differential effects on Black and Brown people. So these include differential access to education, to housing, to employment, differential engagement with institutions of public safety, et cetera. So when we talk about diversity and equity and inclusion in research, what are we talking about? What does that exactly mean? So this idea really cuts across research at all levels, from who is able to be trained as an investigator to how is this research published and is it disseminated and implemented in the community? So really from the beginning to the end. So we're including at the very beginning of the process, ensuring an adequate diversity of investigators. We also want to ensure that there's equity in research funding by major funding institutions like the NIH across social groups such as race or gender. Adequate funding of health disparities research so that the priorities of what's funded reflects the priorities of classes of people that are socially included and excluded. And we want to ensure that health disparities research is a priority. We want to ensure that the methodology of research reflects the concerns that drive health outcomes for people who are historically disadvantaged. So as an example, that appropriate demographics are collected, that demographics around race reflect people's identities as they live in society, that the demographics for LGBT people, which are often not included at all, are included in research, and that particular factors, including social determinant factors, the kinds of that we're asking questions about what particular social factors may actually lead to worse outcomes, that information is being included in addition to narrow biomedical information. We want to create an ethos where communities who are affected by our research are involved in study design and execution and become active participants in the process of research. And we also want to ensure that barriers to research participation are reduced so that members of all communities, and particularly communities who have been historically excluded from research and the benefits of research, have opportunities to participate. And finally, that in the execution of research findings and implementation and development of new interventions, that the effective communities are also a part of that process. So thinking about barriers to diversity, equity, and inclusion in research. So some of these are very sort of striking and objective when we look about patterns of funding at the NIH level, one of our major funding organizations in this country, and we see major disparities in funding by race. So we can see that although there have been improvements over the years, the funding of Black individuals remains about 25% less than the funding of white individuals. And in fact, the funding of all non-white individuals across the board is still lower than the funding of white individuals. And there seem to be several factors that are correlated with this. One is that Black individuals are less likely to be reviewed. When they are reviewed, they're given lower scores. And some of this is explained by topic choice. Up to 21% is explained by topic choice, i.e. folks of experience of historical disadvantage are more likely to invest in research that focuses on the social determinants that most affect their communities rather than biological research. And that appears to explain part of why people who are non-white are less likely to get funded. Grant history is a consideration for NIH study section appointment. So people who have had access to institutions already are more likely to be the reviewers, and their values are going to be reflected on study sections in terms of deciding who gets to be funded. And as it stands now, only 2.4% of the pool of peer reviewers at the NIH are Black. And Black scientists only account for 1.3% of ACNP. So what was our agenda in thinking about how to improve DEI in research? If we lived in a perfect world and we could think about, what our action plan would be. So one of these would be to improve the recruitment of historically excluded groups into CL research activity, and how would we go about doing that? Another was to improve the mentorship of minoritized individuals who are entering CL research. So as we're bringing them in, we're ensuring that they have enough mentored support to thrive within our community and within our organizations. The identification of health equity as a research priority within CL psychiatry, that we understand that the social determinants of health are what most affect our communities of disadvantage, and that needs to be something, an area of active study and inquiry in the work that we do. Increasing knowledge and skills in DEI research among CL psychiatrists. We want to be able to expand the capacity for all of our CL psychiatrists, in particular CL researchers, in thinking about these questions and carrying out the appropriate methodology to answer them. And to ensure that the research products for research in CL psychiatry are high quality, equitable, and free from bias, and that its efforts to develop DEI research capacity building efforts are sustainable over time. So in terms of the development process, we reviewed the relevant literature on DEI and health research across medical specialties and in allied health fields. And I've been sharing some of our findings in terms of the state of the field currently, and also a review of current ACLP resources. And finally, we solicited input from some relevant committees and subcommittees. So in terms of thinking about ACLP research-related resources, so there were the obvious ones for us were the Research and Evidence-Based Practice Committee, which is the committee that is tasked with ensuring high-quality, appropriate research is fostered and supported by ACLP. It's done an excellent job in coordinating with other professional organizations, reviewing policy statements, developing practice guidelines, and thinking about our key clinical areas of interest. So this organization, this part of our organization felt particularly well positioned to engage with some of our goals. And then also the Fellowship and Awards Subcommittee, particularly as a member of as part of the membership committee, also is positioned to support some of our interests. So our recommendations for ACLP really fell into three categories. And the first has to do with recruitment, diversification, and mentorship. And so we recommended that ACLP identify, recruit, and mentor underrepresented minority researchers, for example, via a young investigator colloquium. So again, sort of engaging some of these pipeline issues that we're interested in to bring folks of who are historically excluded from our institutions into our organization and foster their talents, and to promote their points of view and experiences within the organization. We wanted to identify DEI research mentors within ACLP who could function to support these careers of junior investigators, and also to help junior scholars with interest in research who have access only to limited research at their institutions, understanding that some folks of historical disadvantage may be coming from institutions that have a less robust research infrastructure, and what we want to ensure adequate research support and mentorship for them. Our second category of recommendations had to do with promoting DEI research in CL psychiatry. So these included identifying and inviting established underrepresented minority researchers who are not current members of ACLP to attend the annual meeting and join the organization. So again, trying to identify members of communities who have been historically disadvantaged and excluded from ACLP and our other organizations, whose perspectives and points of view and talents would be particularly important in forming our continuing work in DEI. And so we want to ensure that we're extending invitations to those individuals. We also want to identify and invite established researchers whose investigations are focused on health disparities in patient populations of interest to ACLP. So folks who really have rich expertise in these areas that we can engage with and further develop our own work in these areas. We want to encourage trainees and early career psychiatrists to do DEI research in the realm of CL psychiatry and to really see these as important and legitimate areas of inquiry that become the focus of their scholarship. We also suggested starting a special interest group focused on addressing healthcare disparities where champions can connect junior and mid-level and senior people. And finally, sponsoring a research symposium focused on diversity, equity, inclusion. And our last category focused on ensuring best DEI practices in CL published research. So the first recommendation was to review the Health Equity Style Guide released by the CDC and encourage ACLP to adapt its language regarding data or information about health disparities. So the CDC has a very comprehensive health equity style guide that goes through a number of considerations in terms of actually producing research products that are equitable and ensure an inclusive point of view. We also recommended reviewing publications and reviews for use of pronouns and other non-stigmatizing, non-biased language. And finally, to assess articles for at risk of bias and for generalizability to underserved communities in annotated abstracts published online. And that concludes our recommendations for the organization. So I wanted to thank, of course, Dr. Lee for serving amazingly as our leader in the task force, my collaborator on this project working on DEI and research, Brian Bronson, the whole DEI task force membership. I wanted to particularly thank the chairs of the Research and Evidence-Based Practice Committee and subcommittees, whose input was very thoughtful and invaluable. And finally, the ACLP Fellowship Education Subcommittee, which I chair and continue to be a source of inspiration for all of our work in diversity, equity, and inclusion. And so I want to thank you for our time. And with that, I would like to wrap up this workshop. All of us would like to thank you for your attention, and we look forward to your thoughts and comments at the meeting.